Welcome in CardioPharma Tips, and today we are discussing a question that we usually ask ourselves while we are writing down a prescription. Shall we prescribe the medication once or twice per day? It's a fact that most of the medication prescribed in cardiology are taken once per day, like aspirin, clopidogrel, statins, bisoprolol, ACE inhibitors and angiotensin receptor blockers, mineralocorticoid receptor antagonists, and amlodipine. So the questions that we ask ourselves today: what are the medication to be taken b.i.d, meaning twice per day? Let's start with antithrombotics. We have ticagrelor, a famous B2Y12 inhibitor which blocks the ADP receptor, resulting in reversible antiplatelet effect. It is the first choice for STEMI and non-ST elevation acute coronary syndrome, contraindicated in patients with history of intracranial hemorrhage, pregnancy, creatinine clearance less than 15, use of triple antithrombotic therapy or use of thrombolytic therapy. We usually give it a loading of 180 mg and the maintenance of 90 mg twice per day. Dyspnea is the main side effect, and in some patients we may prescribe a reduced dose of 60 mg twice per day for extended long-term use. Enoxaparin is a prototype of low molecular weight heparin, and it's used in patients with low or intermediate risk pulmonary embolism or a bridge to oral anticoagulation in patients with AF or prostatic valves as a second choice after unfractionated heparin. The usual dose is 1 mg per kg twice per day, but we can prescribe a reduced dose of 0.75 mg per kg twice per day for those higher than 70-year-old, or 0.5 mg per kg twice per day if creatinine clearance less than 30. Apixaban and dabigatran, two of the famous non-vitamin K oral anticoagulation. Apixaban is direct factor 10 inhibitor, whereas dabigatran is direct factor 2 inhibitor. We are using them for long-term oral anticoagulation in patients with non-valvular AF, and apixaban can be used in the acute phase treatment and long-term oral anticoagulation in venous thromboembolism. Not approved yet in prostatic valve and valvular AF. The usual dose for apixaban is 5 mg twice per day, while for dabigatran 150 mg twice per day. Let's shift to the rate controlling medication. The most famous beta blocker to be prescribed twice per day is carvedilol, prescribed in doses ranging from 6.25 up to 25 mg twice per day. It is a non-selective beta blocker with vasodilator effect because it blocks the beta receptors as well as the alpha receptor. So it is approved to be used in heart failure and coronary artery disease, but contraindicated in HUCAM due to its vasodilator effect because here it would reduce the afterload. Ivaprazine is one of the famous rate controlling medication. Usually we start with 5 mg twice per day up to 7.5 mg twice per day, acting on the funny channels in the SA node, so reducing its automaticity and reducing the heart rate. We can use it in patients with inappropriate sinus tachycardia, as well as patients with coronary artery disease or heart failure if their heart rate is still above 70 and they are not tolerating or refractory to beta blockers. And of course, it is classified as class 0 in the modern Vaughan-Williams classification for antiarrhythmic medications. By the way, what about antiarrhythmics? We have two famous examples, flecainide and sotalol. Flecainide is a class 1C antiarrhythmic that acts on the sodium channels, whereas sotalol is a racemic mixture of D form that has a class 2 effect and L form with a class 3 effect. Flecainide can be used in patients with SVT, Wolff-Parkinson-White syndrome, cardioversion of AF, and sometimes for maintenance of sinus rhythm, and for patients with idiopathic VT. Sotalol is less commonly used at the time being, but it can be used for patients with SVT, Wolff-Parkinson-White syndrome, maintenance of sinus rhythm, but not approved for cardioversion of AF or for idiopathic VT. And don't forget their famous contraindication, as flecainide is contraindicated in any patient with structural heart disease, whereas sotalol is contraindicated in LV dysfunction and left ventricular hypertrophy, but can be used in patients with coronary artery disease, and this raises the fact that both of them are QT prolongers. Amiodarone is considered to be the joker for antiarrhythmics with a class 3 effect. Can be used in patients with VT, structural heart disease, cardioversion of AF with an IV form, and also maintenance of sinus rhythm. But due to the iodine containing, it causes cumulative side effects like, for example, on the cornea, thyroid, skin, liver, and lung, limiting its use, but still one of the most common medications for antiarrhythmic effects. Dronidarone is one of the new antiarrhythmics that has a fixed dose and with a class 3 antiarrhythmic effect as amiodarone, and it can be used in maintenance of sinus rhythm in patients with AF. And because it doesn't contain iodine as amiodarone, it doesn't have the same problem, but contraindicated in patients with heart failure with reduced ejection fraction with NIHA class 3 or 4, ongoing myocardial ischemia, and creatinine clearance less than 30. Of course, not as effective as amiodarone, but it lacks its side effects. What about the anti-ischemic medication? We have the famous isosorbide mononitrate with doses ranging from 2.5 to 40 mg twice per day. It's converted inside the vascular smooth muscles into nitric oxide, resulting in guanyl cyclase stimulation, increasing cyclic GMP, resulting in vasodilatation of the large epicardial coronaries. So it is used in coronary artery disease and also in patients with esophageal spasm, and it has an 8-hour interval to prevent tolerance to the nitrate. And remember that it is contraindicated to be taken with sildenafil as it results in profound hypotension. Nicorandil is one of the add-on anti-ischemic medication with a dose of 10 mg twice per day. It is a potassium channel opener resulting in potassium efflux and hyperpolarization of the vascular smooth muscle cells, resulting also in vasodilatation of epicardial coronaries. So it is used in patients with refractory angina as an add-on therapy, and it has a nitric oxide mediated vasodilatation effect as an additional effect, which may be a proposed mechanism beside potassium channel opening. Trimetazidine is also one of the famous add-on anti-ischemic medications that shifts the metabolism of the cardiac muscle fibers from fatty acid oxidation to glycolysis, resulting in reduced ATP consumption and reduced oxygen consumption with improved oxygen supply-demand mismatch. So it is also used in patients with refractory angina as an add-on therapy. And as we mentioned the anti-ischemic, we should mention the anti-failure medication. We have the famous revolutionary medication sacubitril valsartan, or the ARNI, which has doses ranging from 50 up to 200 mg twice per day. It's composed of sacubitril, which is a neprilysin inhibitor, and valsartan, an angiotensin receptor blocker. This combination results in significant vasodilatation and diuresis, resulting also in clinical improvement beside LV function improvements. That's why it is approved in the guidelines as one of the essential medication for patients with heart failure. And finally, with some of the miscellaneous medications that we commonly prescribe, we have posentan and endothelin receptor antagonists that reduce vasoconstriction and intimal proliferation. So it is used in patients with pulmonary arterial hypertension, but contraindicated in pregnancy due to teratogenic effect. And also it has a problem being hepatotoxic and expensive, but one of the effective medications for pulmonary arterial hypertension. We also commonly prescribe colchicine as an anti-inflammatory medication that inhibits the beta-tubulin polymerization into microtubules, so it has a significant anti-inflammatory effect used in acute pericarditis, acute gouty arthritis, and also in patients with familial Mediterranean fever. It's prescribed in a dose of 0.6 mg twice per day, and we need to stop colchicine if the patient develops diarrhea. So I tried today to give an examples of the famous medications that we commonly prescribe in cardiology twice per day. Of course, I couldn't give a complete list, so let me know in the comments if you know other medications that are prescribed twice per day. We mentioned the antithrombotics like ticagrelor, enoxaparin, apixaban, and dabigatran, the rate-controlling medication like carvedilol and ivabradine, antiarrhythmics like sotalol, flecainide, amiodarone, dronidarone, anti-ischemic like isosorbide mononitrate, trimetazidine, and nicorandil, anti-failure like sacubitril valsartan or the ARNI, and some of the miscellaneous medication like posentan and colchicine. Thank you very much for watching this video of CardioPharma tips, and we are meeting next week for the medications taken 3 times per day.